Hello, everybody. Welcome back to the show. This is the Science Dispatch Podcast. My name is Cameron English. That is Dr. Chuck Dinnerstein, Director of Medicine at the American Council on Science and Health. Chuck, what's going on? It's great to see you.
Nice to be seen. And yourself? Good?
I've been better. I'm too lazy to go to the drugstore and get a test, but I'm pretty sure I finally caught COVID after 5+ years.
It's about time.
I feel like I'm in the club now. Yeah.
You're in, baby.
Yeah, the sensation of not being able to smell or taste things, it's new. It's foreign. So
it's so weird. I just read an article about that from the pandemic days when they were busy suing Yankee Candle Company.
Who?
People bought their candles because they had nothing to do when they were at home, and they had COVID. So they were sending them back, telling them the candles were defective because they couldn't smell any scent.
Well, that could be a problem because if you can't smell the volatile organic compounds, then you don't know that your endocrine is being disrupted.
Oh, yeah.
And, so you're going to sue them for one reason or another, so might as well get it out of the way up front.
Though I don't know if the candle company is responsible for those endocrine disruptors. Perhaps. If you
Big Candle is in on it. I know this, okay? I heard it from, the organization for...
People from Big Light Bulb told you that this was going on with Big Candle.
Very good. Okay, well, my pleasant lack of taste aside, let's talk about low-dose radiation, Chuck. This is, I don't know, my perception is that this has always been sort of a low-level, pun absolutely intended, sort of controversy that's been hanging around, and there seems to be some disagreement about how serious of a concern this is. So this is an appropriate topic. So this article, this is by one of our contributors, Dr. Frederick W. Granis Jr., who has the coolest name I've ever had to say on a microphone. So that's the first cool thing. Article's called Low-Dose Radiation Carcinogenesis. Are CT scans causing 103,000 excess cancers annually? ? Here's the introduction, Chuck, and then break it down for us. So, are CT scans silently triggering a cancer epidemic, or are we being misled by speculative modeling and media-fueled fear? A new article warns of 103,000 additional cancers from diagnostic imaging, yet offers no empirical evidence, just an alarming prediction based on a controversial theory. Before we let panic dictate policy, it's worth asking, where's the data? Always a great question, Chuck.
So there is a concern about CT scans, and that is fueled by one, that the radiation from an abdominal and chest CT is significantly greater than that from a routine chest X-ray. And over the last, 40 years since CT scans have been available, they've really become the gold standard for diagnosing many chest and abdominal complaints. Whereas, back in the old days, we would rely on physical examination or plain x-rays or God forbid, a day or two of watchful waiting. Today, everybody is run through the CT scanner. So that the amount of radiation that people are getting is significantly greater than at the beginning of my generation. Having then said that radiation, though it's significantly greater, does not appear to be so significant that it makes a difference in terms of cancer risk. And the real risk about cancer gets back to a discussion of how you measure the risk of cancer at exceedingly low doses of radiation. And we don't have any great data at all on that. And the no threshold theory of radiation, which is the model that the U.S. uses, it's part of the concept of the precautionary principle, says that there is absolutely no level of radiation that it is 100% safe. And so, therefore, a chest X-ray can cause problems. A CT scan, which is probably somewhere between 10 to 100 times the dose of a chest X-ray, can increase that risk, and that's become an increasing concern over time. The linear no threshold theory is really based on data that we collected at Hiroshima and Nagasaki. So it's not really the best scientific data to extrapolate from, but it's what we've based things on for years and years and years. So the study, which is I believe comes out of JAMA, is another one of these studies where they look at the radiation doses people have and they compare it to the possible thresholds, which is the secondary model, and they say, look, this causes X number of cancers. And Dr. Granis, who's a thoracic surgeon and therefore is pushing CT scans for the early and better management of lung cancer, has come to this particular phrase saying there's not a great deal of evidence that CT scans cause problems. And I think his probably his best argument to be made about it is that while we've significantly reduced the amount of radiation that people are exposed to with a CT scan over the years, we've seen no increase in the number of cancers that you'd expect if more people were having CT scans, which is the case. So that's kind of in a nutshell the concern. Now, industry has been very good about beginning to capture that kind of radiologic data. In a hospital setting, there is a physicist who is responsible for maintaining the safety of the radiologists and all the radiology staff. But there's nobody in particular that's there to maintain the radiologic safety of the patients. But, we have routine things to do in terms of covering areas with lead or minimizing the risk. But in the last, I would say, 10 or 12 years, manufacturers have tried to calculate the amount of radiation that the patient's receiving from a CAT scan or a fluoro or a chest x-ray and create a database so that we can look at patient cumulative doses over time. Of course, the difficulty with that is that none of our computer systems talk to one another, and the x-ray that's taken in hospital Y is not counted with the chest x-ray that's taken in hospital X, and so we have those usual computer problems that interfere with capturing any kind of real data. That's the story.
I would assume there's been studies done over the years of radiologists and nurses and techs who are consistently working with these testing tools, and presumably that if there's some signal, that kind of research would have detected it, right? Has that been done, or
there is I don't know that I would. If it's a signal, it's a smoke signal, and we all have stories that we can tell about physicians that were a little lackadaisical in how they protected themselves, or were in environments where the protection was not as good as it might be, that went on to develop cancers. But those are anecdotal. That's not a population study. And as I said, when I was working in the cath lab, everybody was wearing lead, and everybody had dosimeters on so that we could measure the amount of radiation we were getting. And if it exceeded the normal level, they just said, you're not going to the cath lab for the next month or two. So there was rules in place for keeping an eye on it. And it's an interesting question. I think that the only group where they have their real, where I think there may be some reason to have concern, are talking about adolescents and children, only because a cumulative radiation dose for a child, they have a much longer lifespan, so that radiation dose may have a bigger effect on them over 30 or 40 years compared to a middle-aged person, where it's not going to make significant difference. I would argue, though, that if you are a 3 or a 4-year-old and you're having a lot of CT scans, there are other problems here that may shorten your life long before the CT scans do.
So to Dr. Granis's argument, which makes sense to me, is that this technology detects actual cases of cancer and helps us identify them early or prevent them.
Yes.
So, not to dismiss this potential or hypothetical risk, because we don't want to do that because it could be serious. But it seems that at minimum we need to do a risk assessment, just a classic cost benefit analysis, and say, well, how many lives is this helping us protect or save, versus this sort of modeling that could very easily be exaggerated. What's your take on that?
Well, I think that you're 100% correct that that's what we need to do. And what's happened is that some of the people that are opposed to this kind of screening, and low dose CT scans for lung cancer are controversial in that it's difficult to identify the actual population at risk. Yes, a 50-year-old that's continuing to smoke 2 packs a day, 1 pack a day, yeah, that's probably a good person. But the question is, do you want to extend that kind of screening to somebody that smoked in their 20s, hasn't smoked in the last 25 years? Are they still at risk? Yes. Is it worth a CT scan? Starts to get a little money there. And I think that what's happened is that the classic way of making a determination of the risk-benefit to the test is how many people undergo the test, what is it cost, the cost for screening. How many thousands of dollars does it cost to identify one person with lung cancer? And the opponents of this have now found a new argument that in addition to costs, it may also cause cancers. And so that's a cost that has not been figured in to the risk analysis before, and they think that it further tips the balance towards their point of view, which is to not do CT scans as a screening test for people at risk for lung cancer.
There's an interesting data point he includes in here. Direct quote, he says, while CT scans have markedly increased over the past 2 decades, cancer rates have gone down steadily. The age-adjusted incidence of cancer, 466.8 per 100,000 in 1975, has fallen slightly to 443 in 2022. So, I mean, to my untrained eye, that would seem to suggest that there's no there here, right?
Well, it's really an apples-oranges comparison. On the face of it, in the face of increasing CT scans, there are decreasing diagnosis of cancer. But there's any number of reasons why cancer may be diagnosed or not. And when you say CT scans, what kind of CT scans are we talking about? Because I can do a CT scan of your head. That's not really what they're concerned about. They're concerned about abdominal and chest CTs more than anything else. And while the data, I don't believe the data is there for either one of them. I think it's a little glib to just put those two facts out there and say that now there's no question.
Okay, so then potentially what could be happening then is that we're getting better at managing other risk factors for cancer, and then this could be causing cases even if the overall number of cases is declining. Is that?
Yes, you put it far better than I did. Yes.
Okay. Yeah. Okay, I just want to make sure I understand that. Well, then as we wrap up here, I mean, what sort of data would settle this, or at least bring clarity, and would it be ethical for us to gather it?
Well, I think that if we had data on actual radiation doses that people had over time on a large population, we could say 10 or 12 years down the line whether there was a higher incidence of cancer in that population. Though, again, as I said, people that are getting lots of CT scans are not getting CT scans just because they have some free time on their hands. And so that's always going to be a confounder to the data. But certainly if we had a way that we kept track of the amount of radiation you received over the course of 10 or 12 years, that would put us in better shape to do that. And as I said, the manufacturers have provided that data at the time of the test being done. That's easy. There's a dosimeter that can go right on the equipment to tell that. But there has been no way for our computer systems to speak to one another, and which speaks to a different problem because the X-ray equipment speaks to the hospital information system through one set of translations, and the hospital system may or may not talk to any of the other hospitals. And we've not made any real gains in 25 years for getting these systems to talk to one another.
Interesting. All right. Well, we've solved another crisis then. Thank you all for listening. Cameron and Chuck with the life lessons you need to learn. Okay. So ongoing situation. It just needs to be monitored. It sounds like on both sides of the dispute, there's potential for conflicts and bias, and it's just going to take a little more scrutiny, a little more skepticism to get to the bottom of this.
And I would say that in today's health system, if the doctor is ordering a CT scan to evaluate for pathology, that's going to give you the best diagnostic information, and it's still worth listening to the doctor and going through with the test.
Good life advice. If your doctor says this might help you avoid cancer, you should strongly consider that opinion. For as helpful as ChatGPT can be. All right. Very good. Well, once again, the article is called Low-Dose Radiation Carcinogenesis. Are CT scans causing 103,000 excess cancers annually? Dr. Granis' answer is probably not. But as I said, we'll keep monitoring this. So thank you for joining us as always. Follow us on social. On X, we're at ACSH.org. I'm at CamJEnglish. We're also on Instagram, Facebook, and YouTube. The account is ACSH Matter of Facts. It's all hosted by our colleague Anna Delaski. She's doing great videos, great infographics, just short little 30-second, 1-minute clips breaking down some of the most pressing science questions that the internet has these days. Speaking of which, if you have questions for us, you can post them to our social media accounts, and we are going to do a whole episode where we answer your science and health questions. So send those in. We'd love to tackle them. Or more accurately, I'm going to ask them, and Chuck is going to tackle them as the guy with 40 years of medical experience.
Okay.
All right. Yeah, I just put Chuck on the spot. Yeah, he's gonna do all the hefty lifting. Heavy lifting. I've got, like I said, I've got the COVID brain fog, so it's not my fault if I say anything wrong. Thank you, as I said, for joining us, and we will see everybody next week.